I cannot share.
Let me set you as the co-host, and then I think you'll be able to. Can you please try that?
Yeah, now I can share my screen.
Perfect. Hi, everyone. Welcome to the 145th Stanford MedAI Group Exchange session. This week we have Dr. Boris Kovatchev and Dr. Jacopo Pavan from University of Virginia to talk about their work on artificial pancreas and contemporary treatment for diabetes. Dr. Kovachev is a professor of diabetes at University of Virginia School of Medicine, as well as an adjunct professor at the School of Data Science and founding director of the UVA Center for Diabetes Technology. He's also the principal investigator for several projects dedicated to diabetes, data science, and development of automated insulin delivery systems known as the artificial pancreas. Dr. Pavan is a postdoctoral fellow at the University of Virginia Center for Diabetes Technology. He received his PhD in bioengineering in 2023. The core of Dr. Pavan's research is to improve how people interact with technologies for diabetes care. Earlier this year, he was also awarded the Breakthrough T1D Advanced Postdoctoral Fellowship to work on the development of algorithms for adapting insulin therapy across pregnancies with type 1 diabetes with the aim of reducing adverse maternal and fetal outcomes. So thank you, both of you, for joining us today. But before we start, do you have any preference on how you would like to take questions? Can we interrupt you in the middle, or do you have like designated breaks in your talk?
The more interrupt, the longer it gets. So maybe at the end is more compact.
Okay. Okay. And how about you, Pavan?
Yeah, same for me.
Okay.
Probably better at the
So,
end, but if you want, you
okay.
can also interrupt in the middle.
So in that case, I think I'll request the audience to hold their questions until the end of the talk. Thank you very much. And without further ado, I think Dr. Kovachev will start first. Thank you.
Okay, thank you for inviting us here. So I'll try to tell you the story of what is now called artificial pancreas. I cannot see you, so I don't know how many of you are familiar with the topic of diabetes and artificial pancreas. So I'll start from the beginning. And the slides should move. Theoretically, they don't. Okay. Let me see this way. Okay, that was too fast. The first part is to formulate the problem, and then we'll go through the development of diabetes technology that is now more than 100 years old. Then we go to quickly transition to the clinic, and then we'll go to the near future. So this is a model of the human metabolic system, and in the center of it is insulin producing beta cell, the blue thing here in the middle. And that insulin producing beta cell is key to the regulation of blood sugar and producing energy when we eat something. So food enters here on the left. Let me get the pointer here. Food and external metabolic perturbations arrive from outside. That includes meal, exercise, and other things. That triggers a cascade of responses that involve liver, gut, brain, muscles, kidney, and the pancreas, most importantly. The two elements of the pancreas that are important for our conversation are the beta and the alpha cell. They are linked by little internal network. The beta cell produces insulin and amylin. The alpha cell produces glucagon, and they are counteractive to each other. Insulin lowers blood sugar levels. It goes to the periphery. It disposes glucose there. And then it goes to the liver and decreases the sugar input out of the liver. The alpha cell does the opposite. It sends glucagon signal to the liver to release sugar. So they're in balance. Essentially, when we eat something, blood sugar goes up, beta cell triggers to go to secrete insulin. Blood sugar goes down. If it goes too low, alpha cell triggers, glucagon kicks the liver to produce sugar, and so forth. So that's the system in health. In diabetes, the beta cell is gone, particularly in type 1 diabetes. So all of this network is disturbed. There is no internal feedback. There is no suppression here. There is no periphery. So the only treatment for type 1 diabetes so far is external insulin injection via insulin pump or insulin pen. And that process requires insulin to go from external device through the skin to subcutaneous tissue to circulation to the muscle, to the liver, and so forth. And that causes big delays. And this is the major problem of automated control of diabetes or any control of diabetes, that between the action of injection of insulin and the action of insulin, there is about an hour delay. As a result, meal challenges and exercise challenges cannot be responded to quickly. And because they cannot be responded to quickly, the swings of blood sugar in diabetes are much larger than in health. Normal blood sugar level is between 90 to 100 milligrams per deciliter, sometimes lower, but that's about it. And that's equivalent to one pack of sugar, 5 grams, dissolved in your entire bloodstream. Half a pack of sugar is too low, that's hypoglycemia. 2 packs of sugar is too high, that's hyperglycemia. So the whole technology that has been developed in the last 100 years aims to keep blood sugar levels at this level, 1 pack of sugar dissolved in the blood, in the bloodstream of a person. And then that brings us to the second point here. Before 1921, type 1 diabetes was generally a death sentence. People were able to live for a few months by severe sugar deprivation, and then they were expiring. Insulin was discovered in 1921 in Toronto by Frederick Banting and Charles Best. They got a very quick Nobel Prize for this discovery. The first person they cured, not cured, but maintained on insulin was a boy at the time in Toronto. That quickly became commercial. Eli Lilly produced the first insulin in 1923. And then for 40 years, that was the only treatment of diabetes. There was no measurement of blood sugar levels, really. Only insulin injection was the treatment. In the 60s, people started thinking about regulating insulin externally and continually. And this backpack insulin pump was introduced that was injecting insulin and glucagon intravenously. So this person had IV lines in their hand, and the pump was injecting insulin or glucagon depending on whether blood sugar level goes high or low. Very inconvenient for use. The first insulin pump that was subcutaneously delivering insulin was invented by Dean Kamen in the early 70s. It was called the auto syringe or the blue brick. It was the size and the size of a brick. That's why they called it blue brick. Dean Kamen is active. We met with him at the recent ADA meeting. Now he has created a new insulin pump that's called Twist out of a company called Sequel, and it's about 100 times smaller than first his creation. People about at the same time learned how to measure blood sugar level. This AIMS reflectance meter is located in San Jose in a museum there of LifeScan. That required a significant amount of blood and took a lot of longer time to measure. Substantial for our talk is the minimum model of glucose kinetics that was developed by Richard Bergman and Claudio Cubelli in 1979. And that was the first attempt to kind of put into equations the glucose metabolism in a person in health. So for the next about 30 or 25 years, the devices became much smaller and the models of diabetes became larger and more complex. And by the end of the previous century, there were several prototypes of insulin pumps. This is a pump, this is a pump, this is Roche, this is Medtronic, this was Animas pump, and this is Insulet pump, and there are several devices for continuous glucose monitoring, Dexcom, Abbott, Medtronic, and others. So when that happened at the turn of the century, people started thinking about closing the loop, meaning automated control of diabetes, or the popular name is artificial pancreas. And the first meeting on that subject happened on December 19, 2005 in Bethesda. At NIH, I was there, and there were pros and cons whether that's even possible, but we decided to try. The former JDRF, now known as Breakthrough Type 1, issued a few grants for 1 year to see whether we can actually do anything with that. The first thing done at UVA was to change the paradigm of testing of algorithms, of control algorithms. Before 2008, the classical paradigm of introducing new medical devices was to do a bunch of animal trials and then go and transition to humans. In 2008, we changed this concept and we created a big simulator of the human metabolic system in diabetes, which I submitted to FDA, and it was accepted as a substitute to animal trials. So now, in our shop and in many other places, that simulator is a major tool. People, including Jacopo, are using it daily. And there are no animal trials in this field in the last 17 years. So this helped moving things faster. 2008, we started to 2011 with first inpatient studies. The person was confined to the bed. There was control algorithm running on the laptop, a lot of wires, but still it was subcutaneous. This was subcutaneous insulin pump, and this was subcutaneous continuous glucose monitor. So there were no IV lines, at least there was no venous anything. 2012, we introduced the first mobile system that was actually capable of going outside of the hospital. This is a picture in nature of the so-called DIA system, diabetes assistant, that we introduced then, and it became the first wearable artificial pancreas. DIAS run a bunch of clinical trials between 2012 and 2015 in various places in the US and Europe. It went to Argentina, it went to Israel, it went to a lot of places. And this is a memorable picture. This is the DIAS remote monitoring screen. I took this picture on January 1, 2015 at 9 o'clock a.m. That was the first New Year night on artificial pancreas at home. There were 7 people on that system and everybody was on the green. When we have green lights here, that's good. That's for hypoglycemia, that's for hyper. There is just some warnings here and there, but everybody is good. So a meta-analysis by the end of 2015 showed that compared to what the doctor can do, which is in orange with insulin pump sensor, the algorithm equipped with the same devices, insulin pump and a sensor, can do better. Doctor is blue, algorithm is orange, average glucose is lower, time in range, which is a major metric, time in the range 70 to 180 milligrams per deciliter is much higher on the algorithm, and hypoglycemia is much lower on the algorithm, and that is particularly pronounced overnight. If you look at these numbers, they hold until today. The commercial systems are doing the same results now, about 74% time in range. So that holds for 10 years now as a result. So then we started translation to the clinic about 2015. We did, for that we needed a very long studies to be done. This trial involved 100 people. Each was 10 months. We called it Nightlight because it was differences between overnight control only and 24/7 control. 24/7 control, and we found little difference between those two modalities. But the point was that it's a very long trial, and the systems proved that they can be at home for a long time. Then we did stress tests, meaning kids, children, and adolescents going skiing on 3 occasions to various places. This picture here is children on artificial pancreas at the top of the Imperial Express in Breckenridge. That's the highest lift in the United States, and the system survived the stress tests. So about that time, it was transferred to a commercial device. This on the left is the experimental system that we had, diodes with the sensor and the pump. The algorithm was plugged into an insulin pump that was called, and still is called, Control-IQ, manufactured by Tandem Diabetes Care. The sensor is Dexcom, and Type Zero is the company that made the algorithm, which we started here at UVA in 2014. So this system is now used by about 500,000 people in 25 countries. It had to go through pivotal trials, which means trials that end up with FDA approval. NIH funded that. It was called IDCL, International Diabetes Closed Loop Trial. It continued for 5 years, completed 5 protocols with over 500 participants in different age groups, and it ended up with 3 publications in the New England Journal of Medicine of that system tested in different age groups. Here on the left is ages 14 and up, here is 6 to 14, and on the right is 2 to 6. So as a result, that system was authorized in 2019 as the first interoperable insulin dosing controller, approved 2019 for ages 14 and up, 2020 is ages 6 and up, and ages 2 and up in 2024. I looked recently at the age range of the people using this system. It was 1 to 92 years old. So kind of it covers it. NIH was happy about that because they funded this trial, put the picture of the Control-IQ system in their report for 2021, and said that this is one of the nicest NIH achievements in the previous 5 years, between 2016 and 2021. And now I'm moving to, so this is out. This is in clinical practice. There are several systems out there that I'll show you very quickly in a second. Now the question that I'm going to discuss briefly is what is next. So here is what was happening since 2005, since we started the JDRF NIH artificial pancreas project. And I told you about these developments already. The simulation replaced animal trials. DIAS was the first portable AP platform. Moving on, several systems appeared in the commercial space. This is Medtronic. There are three generations of Medtronic artificial pancreas system: 670, 770, and 780G. This is the tandem system that carries our algorithm that I showed you already. This is again Medtronic next generation. This is Insulet. Insulet is a pod. It doesn't have any tubing, and it's controlled by a smartphone. This is the so-called islet. Islet is creation of Beta Bionics in Boston, and theoretically it's capable to inject both insulin and glucagon. Then hence the two conduits here. But so far it has been tested with insulin only. And this is the new sequel pump called Twist. And that's the descendant of the blue brick that I showed you in the beginning, made by the same guy, Dean Kamen, in Manchester, New Hampshire. So all of these systems are called hybrid, which means that a hybrid system is delivering insulin 24/7 every 5 minutes, but that's essentially a basal rate. Around meals, it requires user intervention, meaning the person who wears the system would need to estimate the carbohydrate amount of meals of their meal and inject insulin accordingly, which is called pre-meal bolus. So human interaction is required at least 3 times a day. And the question is how to avoid it, how to make the system fully automated. And that's where data science comes in. So in 2023, we introduced the first neural network, artificial pancreas, and I'll stop at it in a minute. Then we did a neural network FCL studies. FCL stands here for fully automated closed loop control. 3 studies were done at UVA Colorado and UC San Francisco. And then we made it learn. We introduced reinforcement learning, and we've done 1 pilot study at UVA in the beginning of this year. So these 3 steps take the rest of my talk, and I'll show you very quickly how this might work. So how to make the system learn, because learning is important for learning the behavior and the patterns of a specific person is important for full automation. Without knowing what the patterns of the person are, meals cannot be really predicted or caught early enough to inject insulin. That's why the systems are hybrid. Learning is needed to figure out where to inject more insulin around meals and when to reduce insulin around exercise. So in terms of model-based controllers, which is everybody until now, all commercial systems are model-based controllers. Even the smallest model, the minimal model introduced by Claudio Cubelli back in '79 that I showed you briefly, has 6 parameters and it's non-linear. So requires real-time re-estimation of these model parameters, and that requires either to linearize this model or to use some optimization, nonlinear optimization, which needs to converge and take some processing time. Alternative approach is to pre-train a neural network with the human glucose metabolism and then let it go and learn as it goes for a particular person. And that's more natural and falls in the field of machine learning. So we chose for the learning algorithms the second approach. First, we encoded, we had an algorithm that we encoded into a neural net. Critical concept for that was to create a saturated metabolic data set. I'm not going to stop at that. It's published in this paper that is referred to down there from Alberto Castillo and many others. And then to convert that insulin dosing rule into neural net. Then we ran a trial that compared the original model-based algorithm to the neural net version of the algorithm. One is in blue, the other is in red, and this is insulin delivery over 48 hours. You can see that the blocks on top of each other, which means that the neural net did the exact same actions as the model-based algorithm. This study is published in the paper under my name and my colleagues that's listed underneath. This is the first attempt to add automated meal bowls to make the system fully automated. A multi-center clinical trial that, as I said, was done at UVA, Stanford, and Colorado. 36 individuals, fully automated closed loop. That's the red cloud of glucose traces versus usual care, which is the blue cloud. And you see that the red cloud is kind of nicer, particularly overnight, where blood sugar levels are much more under control on the algorithm. And the more important part is when we eat here, when people eat during the day, and these post-meal glucose excursions are not announced by the person, they are not higher than the post-meal excursions on usual care where they are announced by the person. So the fully automated closed loop seemed to be working here. And the last step was to make it learn, to make it learning. And we developed two learning algorithms. One was to kind of learn about the basal patterns of the person. The other was to learn about boluses. One was called performance-based adaptation. The other was called bolus priming. And both use reinforcement learning that adjusted to the physiological profile of a person over 24 hours and anticipated meals to trigger pre-meal boluses. This is the number of the trial. It enrolled 15 people who spent 2 weeks on these treatments. The data was presented here. Here I'm just going to show you in this table that what happens when you add learning to fully automated closed loop. On the left side here, you have FCO, that's fully automated closed loop. These are the results from the multi-center trial that I told you, UVA, Stanford, Colorado. The important metric that everybody looks at is time in range. The higher, the better, 67%. This is the study that has reinforcement learning in it that goes up 9 points, and it's significantly different. Average glucose goes down 10 milligrams per deciliter. The daily insulin is increased, but hypoglycemia is not increased that much. Here is 1.6%, this is 2.1%, and the important part is that there is no human interaction in either trial. There is no carb counting or carb announcement. So full automation is achieved here. And here we show that if we add some data science to it, if we add reinforcement learning, it becomes much better. So in conclusion, that's my last slide. I looked at PubMed. There are about 1,000 published closed-loop control algorithms for diabetes. 7 of them made it to the clinical practice, and I showed you the pumps that use them. So if you have any questions now or later, I can answer.
Thank you very much, Dr. Kovatchev. Very interesting information, I'm sure, for all of our audience who don't have clinical background. So any questions from the audience for this section of the talk? Maybe we can have a few minutes to discuss them. Please raise your hand if you need one. If not, then I have one question. With the machine learning, the idea is to be able to predict a person's specific pattern of eating and exercising? I mean, or what happens if you are kind of off your schedule, if you're eating something irregularly or exercising more or less than usual?
Then it catches up, but slower, a bit
Catches
slower.
up at slower. Okay.
Because of the delay of the insulin, that's the important variable there. Insulin is delayed between injection and action.
Mm-hmm.
And if you are able to anticipate it
Then it's
and
quicker
inject
than.
early, then it catches up faster with the meal. If not, then it catches up later. So the more predictable and regular is the regimen of a person, the better it learns about it.
Perfect. Okay. Thank you very much. I think we can move on with the second section of the talk. Jacopo, if you want to go ahead.
Sure. Okay. Well, thank you everybody for having us here today. I will build upon what Boris just presented and show you another one of the possible developments that we are working on for artificial pancreas systems at the Center for Diabetes Technology. And in particular, one of these key research areas is about the use of digital twins to try and enhance what is co-adaptation between people with type 1 diabetes and this artificial pancreas system that Boris was talking about. And in particular, we're using digital twins to try and personalize treatment on the specific person, but also to try and maybe address therapy-related worries, maybe try to use them as an education tool for patients. So just a summary of what Boris was presenting before, the core aim of intervening in type 1 diabetes is to give insulin to people so as to try and maintain their glucose levels within what we call a safe range, this one, between 70 and 180 milligrams over deciliters. You don't use insulin, glucose levels will go high, and this means that you will start breaking fats to search for energy. Glucose will start accumulating in your bloodstream, and it will cause a series of micro and macrovascular complications, eventually leading to organ failures. If instead you use too much insulin, you go hypo, and then your body doesn't really have enough fuel to work with. Your brain won't have enough fuel to work with. You will start experiencing weakness, blurring, if untreated, even serious conditions like seizure, coma, or even death. So you can understand how difficult it is to try and moderate insulin throughout the day. And as Boris was presenting, luckily, we developed a lot of technologies throughout the years to try and address this problem. And the most advanced one at the moment are the artificial pancreas systems or automated insulin delivery systems. And these are now becoming a standard of care. However, what we would like is for people, I was showing this range now, we would like people to have their glucose levels within this range for 100% of the time, like the whole day being within this range. What is actually happening right now with this kind of systems is that we can achieve on average 70 to 75% the time in range. So they work better than previous technologies, but they're still not perfect. Well, the first thing is that we are actually very good at achieving good glucose control throughout the night, but still during daytime, it's more difficult. And this is because of all the factors that Boris was talking about. It's because of diet, of the carbohydrates that you're going to eat, that they have a huge impact on glucose variability. It's because of physical activity and physical exercise that have a significant effect on glucose insulin metabolism. But also, one thing that was observed in longitudinal studies and pivotal studies of these kind of technologies is that you start using these AID systems, your glucose control is going to improve a lot in the first few days, in the first week, and then you're sort of going to reach a plateau in the performances. I'm reporting here an example from one paper. This is about type 2 diabetes, but it's very similar results also in type 1. On the y-axis, we have the time spent in the safe range. We want this to be as high as possible. And here we have different groups of participants that are starting at baseline with very different glucose controls. At time 0, they start using the AID systems. And what we see is that all of this group, more or less, except the last one, are improving their glucose control. But then we reach a plateau. We call this a ceiling effect. And it's still not clear what's the cause of this, why people are not improving any further, but there's some speculation about it. The first thing is that most of the current AID technologies, they don't include any sort of adaptation mechanism to the user physiology. What we have to consider here is that, first of all, different people have very different metabolisms, but also within a same person, insulin requirements might change a lot throughout time. For instance, circadian rhythms could make you more resistant to insulin during the morning with respect to the night. Or maybe hormonal fluctuations due to the menstrual cycle, for instance, will make you more resistant to insulin at the end of the menstrual cycle with respect to the beginning of the menstrual cycle. So you're going to have very different requirements throughout the day, throughout days. And well, the systems, AID systems that are available on the market, they all have different ways to somehow tune the control algorithm and try to tailor the insulin regimen for the specific person. I'm going to make an example here on one system that we are working a lot with. Is the Thunder Control IQ, is the one that Boris presented earlier, the one of the publication on the New England. And for this particular system, we have 3 settings that we can set. The first one is the basal rate, which is basically the insulin that your body will need just to function. It's the background insulin that you need if you were doing nothing. And we have this carbohydrates to insulin ratio that instead gives you an idea of how much insulin you need to counteract a meal. And then we have the correction factor that gives you an idea of how much insulin is going to lower your blood glucose levels. What's happening is that the control algorithm with the Thunder Control IQ pump will use these 3 parameters to try and decide every 5 minutes how much insulin you're needing. And what you can see is also that these numbers, they might change throughout the day to account for the fact that you might have different insulin requirements throughout the day. So we call these therapy profiles, not just parameters. The fact that the way in which these numbers are translated in how much insulin you're receiving every 5 minutes, this is very complicated. It can be complicated for a patient and for their healthcare providers to understand how to translate these into the insulin that you're receiving. Honestly, it can even be difficult for me that I'm an engineer and I work with this kind of algorithms. What is currently done at the standard of care to try and tailor these therapy profiles on the specific people is a process that I like to call trial and error. Basically, you're going to start using an AID system. Your healthcare provider is going to give you an initial set of therapy profiles, which are usually set through some clinical guidelines. Then you're going to use these profiles for a while. You're going to go back to your healthcare providers. They're going to check your glucose data. They're going to check how much time you spent in the safe target range, how much time you were above it, how much time you were below it. And well, after that, they're going to decide to make some changes maybe to your profile, to tweak some number, and then you're going back and repeating this process again. And this is a process that can take months. It's a process that can be very burdensome on the healthcare providers. It can be burdensome and time-consuming for patients. And also, well, you might find yourself sometimes to have some therapy profiles that you're uncomfortable with. Maybe you have your own fears, and maybe you want to be more cautious than what the healthcare provider suggested, and you're going to tweak them. So it's a very long process, and it doesn't account for the fact that maybe your insulin requirements are changing faster than how often you're seeing your physician. So I was talking about the fact that we are not really adapting to the user physiology, but the reality is that we also think that users are not really adapting to the use of an automated system. So the fact is that people might have very different trust in technologies. They can have their own fears, their own worries. Some people might be more scared of hyperglycemia, and they might be very aggressive with their insulin regimen. Some other people might be very scared of hypoglycemia, and maybe they will be more cautious with the insulin they use, and they will not trust completely the system. So they might change the therapy profiles that they receive from their healthcare providers, and sometimes they might engage in what we call self-treating behaviors. So basically, this is when the patients start to sort of mess up with the automated insulin delivery decisions. And then make you a couple of examples. When patients are going very high, they might decide to give themselves what is called a correction bolus. This can either be triggered from the pump, or something that patients could do is inserting a fake carbohydrate intake, a fake meal, to kind of convince the pump to give you more insulin than you require. But maybe you're giving yourself too much insulin. Maybe your pump, the algorithm within the pump, knew that you didn't need that much insulin. Some other times pumps can be wrong and patients know themselves better. The other side of the medal could be that instead the insulin pump give you a lot of insulin, and what you're gonna do is when you're going very low, very fast, eat some carbohydrates, some snack of fast-acting carbohydrates. This could be a sugar tablet or an orange juice, and this is gonna rise back your glucose levels very fast. This can also be very helpful because it can avoid that you go to hypoglycemia, but at the same time, all these self-treating behaviors, they're going to increase glucose variability, and they're going to make it harder for the automated insulin delivery system to manage your glucose control. So how are we handling this? How are we finding new ways to help the AID adapt to the user and help the user adapt to the AID? The way that we decided to try and solve this problem was by using a technology that is called digital twins to try and prompt human-machine co-adaptation mechanisms. Now, the concept of digital twins is being used more and more in a lot of different fields, and I think that this is a concept that is getting more and more loose. But let's stay on the topic of type 1 diabetes management. In this framework, a digital twin is basically a simulator that closely mimics someone's metabolism. What does it mean? It means that it's gonna explain maybe how carbohydrates are ingested, how far they are digested, how fast they will appear in your bloodstream as glucose, how fast insulin will be absorbed, how it will affect glucose levels, how it will be cleared by your metabolism. I'm reporting here one of these papers by Dr. Vila Tamayo. She's a postdoc at our center, and she's been working a lot on this technology, on their development. And basically what we are working with is a system of ordinary differential equations that are gonna try and explain how glucose levels evolve over time, depending on how much you eat and how much insulin you're using. This system of differential equation will be parameterized with some parameters that might have different meanings. Some of them might explain how sensitive you are to insulin. Some other might explain how fast your metabolism is clearing insulin. And basically what we want to do when we build a digital twin is taking data from our patients and try to tweak this number, tweak some of these parameters until the response of this model is able to very accurately reproduce the data that we collected. I'm making an example here. We have this data in orange, we have in blue the simulation that we get with that model, and we start changing the parameters until the model is able to very closely mimic the metabolism of our patient. So now the question is, how do we use these digital twins to try and improve diabetes management? Well, we use them to build a decision support system, basically a smartphone app. And the way we did it was first, we started by collecting data almost in real time from patients. The data that we're interested about are glucose sensor data, so we want to know what are their glucose levels every 5 minutes. We want to collect the insulin infusion that the pump was administering to people, and we want to record whatever carbohydrates intake was recorded by patients. What we will do next when we have enough data to be able to identify the model is to transfer this data into a cloud-based server and use this data to try and identify some of the parameters of this model until we are able to have a digital twin that closely matches the data that we collected. The way that we are doing it is by using a maximum a posteriori approach. And we're trying, this is some approaches that we've been working a lot of time. For a long time, we're really cared about the accuracy of this parameter, about having a model that is physiologically interpretable and that can be safe to use in a healthcare scenario. Now, how do we use these digital twins really? Well, two possible applications that we thought about. One is to try to achieve physiological adaptation. So the moment that we have these digital twins, what we have is actually a playground that we can use to try and simulate what will change if we change something in the therapy. In other words, we have like a digital guinea pig of our patients. And we can use it to test and explore a lot of different changes to the therapy. To make an example here, we start from first simulation is the data with the original therapy profiles. Then we might decide to maybe try and see what happens if we increase basal rate by 10% during the day. And we see that with this change, the glycemia will be very low, and this is not good. But how do we decide what is good? We define a cost function. In this case, what we want to try and minimize is how low you go, how high you go, and how many times people are expected to engage into self-treating behaviors to avoid risky situations. Once we have this cost function, we can use a gradient-based optimization approach to try and find the perfect modulation for those therapy parameters, for the basal rate, the carbohydrates ratio, and the correction factor. I'm making an example here, maybe after 100th step of our algorithm, we are able to get to these results. We see that we don't improve any further, so we decide to send this therapy recommendation to our patient. And here I'm reporting the work by Jenny. She was describing and designing this whole system for optimization of therapy profiles. Once we have it, the way that we send it back is by a smartphone app. So we developed this one app. It was developed in several pilot clinical studies before this one by Patricio Colmena and other people at the center. And basically, it's an app that patients can use anytime to check their glycemic outcomes. They can use it to receive these recommendations. The way that we designed this was to send the new recommendations every 2 weeks. And what they will receive is this. They will receive how to change the basal rate, their correction factor, and the carbohydrates to insulin ratio at different times of the day to accommodate different insulin needs throughout the day. And then the participants can just decide if they like this recommendation, they want to use it, or if they don't. So as I was saying before, here, patients' behaviors and patients' worries play a huge role, probably in every chronic disease management, but particularly for type 1 diabetes. It might be that maybe they don't trust this technology this much. Maybe they are hyper scared about either hyper or hyperglycemia, and they don't really trust what they received. So another feature that we implemented into this system is a tool for behavioral adaptation. Basically, what we did was taking these digital twins, putting them inside the app, and giving people the possibility to interact with them, to play with them, and to try and see what would happen if they make some changes to their therapy. So for instance, they just received this new recommendation. They can decide to try and test what would happen if I try to be a little more cautious overnight and give a little bit less insulin. Well, what will happen is shown then here in this plot that you can see on figure B. And they will also receive some feedback on how the glycemic outcomes are expected to change if they make the change that they have in mind. So in this way, maybe they decide to trust the system, maybe they don't. Anyway, we expect them to maybe address their fear somehow and maybe to learn more about how these therapy profiles will affect their glucose management. So overall, what we're trying to do is to switch from this old paradigm, this clinical guidelines plus trial and error process that can be very time consuming for patients and healthcare providers, into something that is based on this digital twins technology, something that we call adaptive biobehavioral control, or ABC in short. So we will have people collecting data from people continuously, people receiving recommendations on a frequent basis, people having the possibility to interact with this model and to test the different changes to their therapy. So we expect this process to be faster, first of all, because we can do 100 of simulation in hours. We expect this to be safer because we are testing therapies first on the digital twin and then giving them to the patient. And we're also expecting this to be able to maybe address changes that are very fast, like maybe every 2 weeks we can have a different optimization of the therapy. So in every means, this could be an improvement with respect to the current standard of care. Now, how did we test this technology? We did it in this large clinical trial. We tested 3 different interventions. So all one of the eligibility criteria for this study was that people were already using an AID system. The first intervention that we are trying is just for 2 weeks, letting people use their system. Then for 4 weeks, we are giving them a very simple decision support system where they can only see their glycemic metrics, they can see some risk score, and we call this information feedback. Basically, there's no digital twins here, there's no recommendation of the therapy. It's just an app that you can use to have a better management of your diabetes. And lastly, we're going to try our AID system plus the ABC. So why are we using here 2 different decision support systems? Well, we're curious to see if people are improving because of the digital twin technology, or if they're just improving because they're using a decision support system. So this is why we're testing two different ones. And also, this trial was designed to be a randomized crossover trial. So people are randomized into one of two possible groups. In the first one, that we call escalation of treatment, they start without the decision support system, then the super simple one, and then they use the one with digital twins. The other arm, the escalation arm, will go the other way around. So they start with all the technology, then they drop the digital twins, and then they drop decision support at all. Why we are doing this is because, well, we want to reduce the risk for study effects. So what we want to see is that if people are improving just because they're joining a clinical trial, or if they're improving because the technology is actually working. So what we would expect here is that people in the escalation of treatment will improve over time. Instead, people in the de-escalation of treatment will either go worse or maintain more or less the same glycemic outcomes. The ABC intervention that we developed was used for 16 weeks. They're receiving a recommendation every 2 weeks. So in total, they're receiving 7 recommendations. And when they receive them, they are free to decide to use that or not use it or change it. They have the possibility to talk with the physician and decide together. And they're also asked to use every day the app, to at least access the app once a day to make sure that they were adhering to the treatment. So the results of the study are these. We had 72 participants in total, adults, mostly white, mostly female, mostly non-Hispanic. This is a limitation of the study. It's very common for a lot of studies in type 1 diabetes, unluckily. We had 38 people in the escalation group, 34 in the de-escalation. And here, what we are reporting is the percentage of time that is spent in the safe range. And we're reporting here for the escalation group, first AID only, then AID with the super simple information feedback, and then AID with our ABC system, and the other way around for people in the escalation group. And this baseline data is basically data that we collected during 2 weeks before starting the study, 2 weeks before randomization. What we can observe here is that, first of all, there is no change for people in the escalation group when they join the trial, when they start using the super simple decision support system, but there's instead a huge boost in performances when they start to use our ABC system. On the other way, instead, what we are seeing is that for people in the de-escalation group, they improve immediately when they start using our system, but then they don't worsen. So basically what's happening is that there's some sort of carryover effect. The improvements that they achieved when they stopped using the ABC systems, they're not lost over time, or at least they're not lost in the 6 weeks that we followed them up after, which might mean that either the physiological adaptation that we achieved was good for that participant, we were actually able to tailor glucose control on them, or maybe people have learned during the experience with ABC how to manage the diabetes better, how to address some therapy-related fears. The improvement that we can see here was statistically significant, was around 5%, which is also considered to be clinically significant for participants. Then reported the results here. So we have the first arm, the escalation, the second arm here. And here we have some important glycemic outcomes. As Boris was saying, the one that we always care about, and it was the primary outcome of the study, is the time in range. What we see is that when people were switching from the information feedback to ABC, they had on average an improvement of almost 5%, an improvement that was found to be statistically significant between the two groups. And then we didn't find statistically significant results for the other metrics, but what we can see is that time below range was more or less on average remaining the same. Time above range and average glucose were having a non-significant but decreasing trend over time. Another analysis that we performed was dividing participants into subgroups depending on their glucose control at baseline. So in this case, we use this one metric, that is the glycated hemoglobin. Basically, it is a measure of long-term glucose control. The higher it is, and the worse your glucose control is. So we have first people with a worse glucose control, and then people progressively getting better at baseline. And what we can see is that on average, more or less all the groups improved from the first 2 weeks of ABC to the last 2 groups of ABC, but the people that were worse controlled were the ones that were actually achieving a way larger improvement in time in range, around 6% for the people with the worst control, 4.6% for this other group between 7 and 75% HbA1c, and these two were also found to be statistically significant. Well, we were discussing about the fact that many AID algorithms do not adapt to the changing physiology of the users, and then none of them in particular provided interactive means for users to understand their glucose control, to understand how these AID systems work. What we found is that the ABC system can help them in two ways: by triggering adaptation mechanisms of the AID control algorithm to the changing physiology of the users, but also by prompting adaptations of users' behavior to the intricacies of these AID systems. In a randomized crossover trial, we found out the human-machine adaptation was able to improve glycemic control beyond what are considered the capabilities of these AID systems. We were able to hire a little bit higher the ceiling to the performances that I showed at the beginning. And it really seems like these digital twins technologies can promise to improve the use of AID system and technologies for people with type 1 diabetes. Thanks.
Thank you very much, Jacopo. Before we move on to questions, I'd like the audience to give our speakers a virtual round of applause. Thank you very much for your very interesting presentation. And then the floor is open for questions. Please go ahead and ask if you have any. Otherwise, I think I'm gonna start with one. Jacopo, very interestingly, I'm just wondering because I don't have any clinical background, this model of like insulin and how it is reacting to the blood sugar, does it take into account kind of demographics or like generally the clinical status of a patient? I'm assuming that this model would be sensitive to maybe the weight of the patient, like your BMI.
Yeah, actually, this is the only
important?
one variable that you can see here out of the demographics. It's actually the body weight of the patient.
Okay.
The reality is that, as I was saying, we are not identifying all of these parameters that we have in this model because that would be impossible. There will be an infinite combination of these parameters that will be able to explain the data that we have here. So we're identifying only some of them. For others of them, what we are doing is using maybe some clinical guidelines on how to set them to values that might make sense to the patient. And the way that we do is maybe by using some regression law, using age, body weight, and body height to decide how to set those parameters. An example of this is the clearance of insulin that is set using one of these models. So I would say that these are the only three demographics that we are using here. The rest is everything is coming just from data from sensors.
That's and this kind of artificial pancreas, I think this question is for both of you. So this has been like a technology long in development. Do you is in this study, have you ever focused on patients who have like other comorbidities, for example, like transplant patients or patients with heart disease? Does that make a difference to the performance, or are the models just good enough to handle kind of severe history of illness?
Well, maybe Boris can reply better to this one, but just one comment specifically regarding this one trial is that, well, of course, when you do this kind of studies, you usually have inclusion criteria and exclusion criteria that remove some comorbidities that might be difficult to deal with, that might maybe bias the results. In this case, I want to say that we were pretty loose, and I'm just making an example. Maybe we might have in some of these clinical studies participants that were undergoing cancer or they were undergoing some other disease that at some point might require the use of steroids. This is one particular example that happens in some of these clinical studies. And steroids have a huge effect on insulin sensitivity. So what was happening sometimes is that whenever patients were using steroids, what would happen is that insulin you will completely mess up insulin requirements during those few days. likely whenever we take these decisions for optimizing the therapy, we're taking several days. We were taking 2 weeks of data. So on average, what will end up is that you're going to consider what is the average control for that one participant. And somehow this is excluding these sort of little scenarios in which you might have the use of steroids or whatever else.
Okay, that makes sense. I was just asking because I think it's I can see that you're presenting this technology which has been FDA approved and commercialized. So I was just trying to understand like the full scope of application here. But very interesting, very impactful work. Thank you very much for presenting it.
Thank you.
Thank you.
So we are, I think, just about at our time limit. So if anybody has any questions, maybe we can put them in touch with the authors later through email. Thank you very much, everyone, for joining us. And thank you very much to our presenters. Have a nice day.